Good morning all. Today we discuss about arch expansion part 1. The correction of transverse maxillary deficiency can be important component of orthodontic treatment plan, and numerous factors can be result in the transverse maxillary deficiency, including genetic, environmental, traumatic, and functional, which include the abnormal habits such as, for example, mouth breathing. These all can cause the deficiency of mandible in a transverse dimension. First, the emergency angel is considered the father of rapid maxillary expansion. There's a two type of expansion, rapid and slow. Emergency angel is the father of rapid maxillary expansion, and Walter Coffin is the father of slow maxillary expansion. We already told the classification of maxillary expansion, rapid and slow. By classification by McNamara, it is called dental expansion and skeletal expansion. Mainly the dental expansion we got by using the slow expansion of planes, and skeletal expansion got from the rapid maxillary expansion. What are the indications of maxillary expansion? First one is crossbite. Second one is mild crowding. Third one is the expansion along with, we can also use along with the functional appliances for skeletal class 3 malocclusions, distal molar movements, and surgical orthodontics. These are the main indications of maxillary expansions. Today we mainly deals with the rapid maxillary expansion. In rapid maxillary expansion, the rapid palatal expansion of split palate. We split the palate. We all know that the will have to have some going by a mid-palatal suture. We split this palate. Before we go into rapid maxillary expansion, there is a simple anatomy of maxilla. Maxilla is a paired bone that articulates with its opposite member and its various other bones, including frontal, ethmoid, nasal, lacrimal, vomer, zygomatic, and palatal bone. The maxilla together with the palatine bone form the hard palate. It's the floor and the greater part of the lateral wall of nasal cavity. Most of the suture attachments of the maxilla to the adjoining bones are at an posterior and superior aspect, leaving the anterior and inferior aspect free, which make it vulnerable for the lateral displacement. Because of this reason, we can expand in transverse direction, because its anterior and the inferior aspect of the suture are free compared to the posterior and superior aspect. The intermaxillary and interpalatine sutures are collectively called mid-palatine suture. The rapid maxillary expansion should be initiated prior the ossification of the mid-palatal suture. And we should use this rapid palatal expansion before the mid-palatal suture ossification. It is commonly occurred in girls in 16 years, but in boys it may be in 18 years. So before this period, we can use rapid palatal expansion or rapid maxillary expansion for expansion purpose. What are the indications of RME? First one is posterior crossbite. The posterior crossbite is associated with real or relatively maxillary deficiency. You all know that if any maxillary deficiency, there's a chance of posterior crossbite is more. Second one is the class 3 malocclusions. Class 3 dental or skeletal cross. We can use anterior or posterior crossbite correction. We can use RME, mainly for the posterior crossbite correction. Third one is along with face mask therapy. RME is used along with the face mask to loosen the maxillary suture attachment so as to facilitate the protraction of the maxilla. Next one is cleft palate patient. Cleft palate patient shows mainly collapsed maxillary arch, so we can use RME for correct that. Next, some medical conditions like nasal stenosis, poor nasal airway, septal deformities, the recurrent ear and nasal infections, and allergic rhinitis, DNS. DNS means deviated nasal septum. These all conditions are the main indications of RME. What are the diagnostic aids we need to before we start the RME treatment? We should take a proper case history and clinical examination. Also, we should have the study model, so we get a more idea about the how much expansion we needed, and for get an idea of mid-palatal suture ossification, we should take maxillary occlusal radiograph. Now, PS cephalogram is also a valuable diagnostic aid for the comparison of how much expansion we got, or to diagnose it is a skeletal problem deficiency or the dental deficiency. We get more idea by using PA cephalogram. Next, what are the effects of RME? Effects of RME. First one is effect on maxilla. Maxilla to open the mid-palatal suture and move the helping downward and forward maxillary movement. Effect on maxillary teeth. We can see a midline spacing like diastema between the two maxillary central incisors, and the maxillary posterior teeth shows a puctal tipping and extrusion. On mandible, it results in downward and backward rotation of mandible. Because of this reason, it increases the facial height. Next one, reduction in overbite. Next, effect of RME on nasal cavity, which reduces the resistance to the nasal airflow. So it increases the intranasal space, so to reduce the resistance to nasal airflow. These are the main effects of RME. Next one, the types of RME. There are two types of RME: removable RME and fixed RME. Removable RME means name itself. It can be removed by patient itself, but mainly the fixed RMEs are used compared to the removable RME. In fixed RME, we can classify it into two types: tissue or tooth-bone RME or tooth-bone RME. Tooth and tissue-bone RME or tooth-bone RME. Examples for tooth and tissue-bone RME are Hirschfeld type and Haas type, and tooth-bone RME, Isaacson and Hyrax. The tooth and tissue-bone RME means it takes the support from the tooth and tissue. But in tooth-bone RMEs, it takes the support only from the teeth to the applies. You can see the two types of RMEs, bonded and banded RMEs. The bonded RMEs are mainly used in mixed dentition type, and the banded RMEs are mainly used in after the all permanent teeth are formed. We can use the banded RME. Then mixed dentition period, we can use bonded RME. Hirschfeld type. In this type, you can see that the first premolar and first molars are banded. There is a wire tag or soldered on the palatal aspect of band, and these wires are get inserted in a acrylic plate. These acrylic plates are split by using and incorporating a screw in its center. In Haas type, same like the previous one, the first premolar and molar on the either side are banded, and a thick stainless steel wire is wire of about 1.2 mm diameter is soldered on the buccal and lingual aspect of the premolar and molar band, connecting each other. So it acts as a single unit, and there is a lingual wire is kept longer as to extend past to the band both anteriorly and posteriorly, and this band is attached to the acrylic part, and there is a two acrylic part separated by a central screw. But in Isaacson type, we already told it is a tooth bone. So it takes support only from the tooth, like premolars and molars. Molars are banded, and it is connected by a expander coil in center, and there is a nut that can be compressed the coil. And the coil spring is made to extend between the lingual metal. The flanges that has been soldered, and expander is activated by closing the nuts, so the spring gets compressed. Next one is the Hyrax type. This type of appliance make use of special type of screw called Hyrax screw. These are this is the most commonly used RME. Name itself, it is a very hygienic rapid expander. Patient can easily brush and keep the oral hygiene. The screws have a heavy gauge with the extension that are adapted to follow the palatal contour and are soldered to the bands on premolars and molars. This is the first part of this arch expansion. In next class, we discuss about the activation of the RME and activation of the RME and the slow expansion.